All right, it looks like it's 10 o'clock, so I'm going to go ahead and get started now. So good morning, everybody. My name is Alex Peters, and I am an outreach specialist for the Wisconsin Comprehensive Cancer Control Program. We staff and facilitate the Wisconsin Cancer Council, our state's diverse cancer control coalition. Again, thank you all for joining this morning. We appreciate you taking the time out of your morning to join us for this important webinar on tobacco treatment for cancer patients who smoke. Our goal with these calls is to share interesting, relevant information with you that you can hopefully take back to your own work, and more importantly, we're going to leave time on each call for discussion and conversation with the presenters, the Wisconsin Comprehensive Cancer Control Team, as well as your fellow council members. So with that, it is my pleasure to introduce our presenter this month, Allison Gorilla. Allie holds a master's in public health and is the UW Center for Tobacco Research and Interventions Outreach Specialist for Southeastern Wisconsin. She's based in Milwaukee, and Allison assists healthcare organizations with improving their standard of care for treating patients who use tobacco use. She provides training and technical assistance to healthcare providers within hospital systems, community health clinics, mental health and AODA treatment centers, dental clinics, and county health departments across her region. Today, Allie will discuss evidence-based tobacco cessation interventions with a special focus on how you can help your cancer patients who smoke to quit. It is our hope that after today's webinar, you will walk away with the inspiration and important knowledge and skills necessary to help your patients quit smoking. Thank you, and with that, I'm going to hand it over to Allie.
Thanks, Alex. All right, so let me bring up my slide. Okay. So thanks, Alex, for the introduction. Can everyone hear me okay? Is there any echo? Nope, okay. Well, thank you again, everyone, for joining me. I am going to be talking about tobacco treatments for cancer patients who smoke. I have no relevant disclosures. So today's talk, I'm going to cover 3 items here: tobacco treatment and why it should be seen as the 4th pillar of cancer care. Then I'm going to provide an overview of evidence-based tobacco treatments. And lastly, how the UW Center for Tobacco Research and Intervention. Sorry, I'm hearing an echo.
I'm sorry. Hey, Allie, I just muted somebody who came in, and that might have been what was causing that.
Okay. All right, hopefully that's a little bit better. So the last topic I'm going to talk about is how the UW Center for Tobacco and Research can help you integrate your tobacco treatment knowledge into practice.
Ellie, you sound just a little bit muted now. Sorry for these audio issues.
Let me switch to the headset. Does that sound okay?
Oh, you sound perfect now.
Can you hear me okay?
Yes, that sounds great.
Is there an echo?
Not currently.
All right, sorry, I didn't share one on my end. So, all right, we will. So,
Ellie, you went back to sounding kind of muted and far away from the phone.
how is now?
That's much better.
That's better?
Yes, that sounds great.
Okay, sorry about the technical problems. So smoking directly causes 1 in 5 deaths in the United States. It attributes to 13 different types of cancer, and 1 out of 3 cancer deaths are caused by tobacco. It contributes to 30% of all cancers, including 90% of all lung cancers. 30% of all cardiovascular disease, and 90% of all COPD. Despite the known risks of persistent smoking, though, approximately 10 to 30% of all cancer patients continue to smoke after a cancer diagnosis, and 1 in 10 cancer survivors still smoke. Continuing to smoke after a cancer diagnosis is associated with an increase in all-cause mortality, cancer-related mortality, and these together decrease the overall survival for patients and decrease their quality of life. Smoking is associated with increased risk of reoccurrence and second primary cancer. It also diminishes the effectiveness of cancer treatments. So we know that at the end of radiation therapy, response rates are lower for patients who continue to smoke versus those who have quit prior to treatment or non-smokers. It can reduce the effectiveness of chemotherapy because smoking increases the clearance of chemotherapy drugs by the liver. So oftentimes higher doses are needed, so we know smoking is associated with increased side effects, but also complications from the 3 standards of cancer treatment. For example, it is associated with higher complications from surgery. It leads to more longer lengths of stay. It compromises wound healing, and the outcomes for surgical treatments are so impacted by smoking that many surgeons now will not operate unless a smoker has been abstinent for a few weeks. Several studies have shown that patients' desire and motivation to quit tobacco increases after a cancer diagnosis, particularly if their cancer is known to be related to their tobacco use. But cancer patients have unique challenges in quitting. They often struggle with high levels of stress and anxiety and depression. They're often older with multiple failed quit attempts, so they feel demoralized, and they may be taking more complex medication regimes. And this can all just make quitting, the idea of quitting, seem overwhelming. I wanted to talk a little bit more about the connection between smoking and behavioral health symptoms, because I think this is a connection that is often not made for patients as an additional reason why they should consider quitting. We know that tobacco use can worsen psychiatric symptoms. This is often contrary to what a lot of smokers believe. They feel that right before they smoke, they often feel nicotine withdrawal. Those nicotine withdrawal symptoms can look a lot like stress, anxiety, and depression. And when someone smokes and that dopamine gets released into the brain, those symptoms immediately go away. So that has created an association for many smokers that their smoking relieves their stress, that it helps them cope with stress. Really, though, what it's doing is my audio still okay? Can everyone hear me?
Yes, you sound great. Allie, you still sound good. Are you still there?
Hello?
Allie?
Can you
Hey,
still
Allie?
hear me, everyone?
Allie, yes, I can still hear you.
Alex, if you can hear me, can you?
Allie, we can still hear you.
Okay, great. Sorry, I just hung up my phone and I wanted to make sure everyone could hear me. All right. Sorry about that. So we know that it does, in fact, worsen psychiatric symptoms. It can worsen, tobacco use can worsen and contribute to the manifestation of psychiatric symptoms in the future. But if you can help someone to quit, there is a meta-analysis of more than 19 studies that show that when someone quits, their levels of anxiety, stress, and depression actually go down and their quality of life improves So if you can impart that knowledge to your patient, I think that can kind of adjust some of their beliefs around their smoking and the role that it plays in relieving their stress. But it also can be an additional motivator for them to quit. And as both smoking and psychiatric symptoms co-occur among cancer patients, screening for tobacco use as well as psychiatric symptoms and providing treatment to both of those at the point of care will really benefit your patients as far as their cancer treatment outcomes. So despite this opportunity that a diagnosis presents and the recommendations from the National Comprehensive Cancer Network that all patients with cancer be offered treatment to help them quit smoking, such treatment is an often neglected element of cancer care. So we know that less than 40% of cancer centers are recording smoking as a vital sign. That's really the first step. That's compared to 95% in primary care centers, and less than half have a dedicated personnel to provide tobacco cessation clinical services. Tobacco cessation treatment delivery was not perceived as a core health service by a survey that NCI did of cancer centers. So it's just not seen as a priority in the oncology setting. But I think that given the information I've provided about how smoking impacts those cancer treatment outcomes, uh, there really is a compelling case for viewing tobacco cessation as essential a component of oncology care as, say, radiation, surgery, and chemotherapy. So it's really the fourth pillar of cancer care treatment to, like I said, improve the effectiveness of cancer treatments, but also avert future cancers. And the good news is that evidence-based tobacco treatments for patients in general also apply to oncology patients. So what do those evidence-based treatments look like? So the knowledge that we have about what works to help patients quit comes from the U.S. Public Health Service clinical practice guidelines. Their recommendations are that counseling alone is effective, medications alone are effective, but when you combine those two treatments, that's where we see the most effectiveness in helping our patients to quit. Their third recommendation is that clinics and healthcare systems think about a systematic way of integrating counseling and medication so that every patient is getting screened for their tobacco use and offered these treatments. So next I'll talk a little bit more about what those health system changes look like. And so when CTRI works with clinics, what we often are starting with is thinking about a protocol, and that protocol is what we refer to as the 5 A's. So I'll provide an overview of that right now, but we're often working with clinics to help them to integrate the 5 A's and take a team approach to this so that it doesn't just fall to one person's shoulders, that it is integrating all the clinical staff at the appropriate points so that it is fitting seamlessly into the clinic workflow. So we have tobacco use identification at the top, asking that question, providing brief advice to quit, assessing willingness to quit, and then based on that patient's motivational readiness, if they are ready, providing those two treatments of counseling and medication, and then providing motivational interventions if they're not ready. I'm going to focus mostly on how to help those patients who are ready for the purposes of today's presentation. And then I'll talk a little bit about some options of pre-quit use of NRT, as well as reduction counseling for those who aren't ready. The last A is arranging for follow-up, and I'll go into a little bit more detail about what that could look like. So the ask question is, because relapse is so common, it's important to ask this question at every visit. And in this question, we have the time frame of the past 30 days, and we incorporate many forms of tobacco to capture a complete picture. If someone's using many forms of tobacco, you'll be able to capture that here. And if someone has recently quit because of diagnosis, you may also want to incorporate a question about ever using tobacco in their life to know if they've recently quit. They may be at more risk for relapse, and how you can support them in maintaining their quit status. So providing brief advice, we know that even just providing advice can motivate and encourage people to quit. So that's an important piece of the tobacco treatment intervention, being clear, direct, and personalizing that advice. For example, if a patient is facing an upcoming surgery, to talk about some of the risks of continuing to smoke. The research shows that actually patients are more receptive to hearing some of the benefits of cessation. So here might be a good opportunity to talk about what those benefits might be, and you can, personalize that to the individual situation. If they're facing surgery, as I mentioned, that quitting can decrease the risk of infection, they can have faster recovery. And certainly providing a patient handout on some of that information is good to think about as well. So assessing willingness to quit is an important question, just to get a chance to hear where that patient is at, not making any assumptions about their readiness, but then that allows you to tailor the intervention to best help that patient. So, and you also might need to tailor this question to the individual patient situation. For example, if they're facing surgery or another cancer treatment at a sooner timeline, like a week, what are your thoughts on quitting in the next week? So there are 3 essential components to assist patients who are ready to quit, and those are a brief counseling intervention, medication, and then connecting that patient to support outside of your office hours, outside of the oncology clinic setting. And who can provide these components? We really encourage clinicians to have an expansive view of who can provide tobacco treatment. You don't have to have a degree in counseling. You don't have to be a certified tobacco treatment specialist. So nurse navigators, pharmacists, certainly prescribing providers are going to be handling the medication piece, but really anyone can provide brief counseling and a referral to support. So when we talk about a brief counseling intervention, the time frame that we are thinking about is 3 to 5 minutes. So this isn't going to be an extensive conversation, but it's just going to get that conversation started and get that person who is motivated to quit to mentally prepare for their quit attempt. And so the 3 pieces of this conversation would be to encourage that person to set a quit date, get them to anticipate 1 or 2 of the major challenges they think they're going to face in their upcoming quit attempt, and ask them to think about how they're going to address those challenges, because people are more likely to go along with their own solutions and ideas. So this is an opportunity for you to pose some questions and then just listen. And then the third question that you're going to ask your patient is, if they have quit in the past, what has worked? And the goal of this last bullet point is to, 1, get them to think about their successes in the past, and that can hopefully boost their morale and confidence that they can do this again. The second goal of this is to think about the strategies that have worked and to bring that with them into this next quit attempt. So for example, if they've used a medication like the patch, the nicotine patch, and that has worked, then that kind of takes the guessing out of what medication should you start with for this next quit attempt. They've used it and it's worked in the past, so that's a good place to start from going forward. Second component of brief counseling is to talk about, or of an intervention to help people be successful, is talking about the medications. And there are 7 FDA approved medications that can reliably increase long-term abstinence rates. So I'm not going to go into all the nitty-gritty detail about the medications. I'm going to point out a resource that has all the information that you would want to know regarding dosaging and side effects and other information about the medications. But I'm going to provide an overview here and then provide some updates on the medications that I think would be good to be aware of. So there are two non-nicotine prescription-only pills, varenicline, also known as Chantix, and bupropion, also known as Wellbutrin or Zyban. And one thing to note, because I did talk about the psychiatric symptoms that often manifest as a result of cancer treatment or a cancer diagnosis, that bupropion has dual action as an antidepressant and as a tobacco dependence treatment medication. So it's a good one to consider for patients who are experiencing depression or who have a history of depression, but doesn't have to be exclusively used for those patients. So, and then there are 5 nicotine replacement therapies. The patch, the lozenge, and the gum are available over the counter, and the nasal spray and inhaler are prescription only. A couple of things to note regarding the nicotine replacement therapies. Medication adherence tends to be a little bit more of an issue with these medications because compared to taking a pill twice a day, you have to take the gum and the lozenge multiple times throughout the day. So if someone already has a complex medication regimen, those options, it's just something to consider and a question to pose the patient. Do they think they could handle taking the gum or lozenge many times throughout the day? And if that might be difficult for them, going with the patch or one of the non-nicotine pills might be a better option. So like I said, at first when someone's quitting, they really need to be taking the lozenge or the gum every hour. And then when they anticipate experiencing a strong craving, those fast-acting ad-lib NRT agents like the lozenge, gum, nasal spray, and inhaler are going to work best to relieve cravings that kind of come out of nowhere. Whereas the patch is going to give a steady dose of nicotine throughout the day. The other thing is that people often think nicotine gum, okay, I'm going to chew it like regular gum. The gum should really be direct your patients to chomp down to release the nicotine, park it in between their cheek, and it absorbs into the gum line. And they get a tingling sensation from that. When that goes away, move it to the other side, chomp down to release more nicotine, move it to the other side. So both not taking as directed or not taking enough of these medications will negatively impact their therapeutic effectiveness, and people often just say this just isn't working for me. So just making sure your patients are aware of how to best use these medications to enhance their effectiveness. So this is the resource I wanted to point out that you can access on the CTRI website. We have a tab for providers that has all sorts of provider materials that are really great to incorporate and just to educate yourself about counseling and medications. So you can find this resource, and it can be provided to you with the slides as well. So the a few updates I wanted to provide on cessation are 7 medications is a lot to remember. There's 2 treatments in general that we know are kind of leading the pack in terms of effectiveness. So I'll talk about those. The black box warning that was tied to bupropion and varenicline, I'll provide an update on that. The FDA label updates for NRT, a new way of using the NRT before a quit date, and then lastly, the Medicaid coverage for cessation medications. So compared to placebo, all of the 7 FDA-approved medications are effective in increasing likelihood of abstinence, but if there's 2 that you were to keep in your back pocket, in your memory bank, they would be varenicline and combo NRT, combination NRT, and I'll talk about what those combinations are next. But these are really the 2 pharmacotherapy options that our research shows to be the most effective compared to bupropion or just prescribing the patch by itself or the gum by itself. So the combinations of medications that you can prescribe are listed here. The patch and bupropion are FDA approved, but certainly the others are great options and are utilized highly in clinical settings. So again, the patch is going to give the steady dose of nicotine throughout the day, but pairing that with a fast-acting agent can help blunt those strong cravings. So bupropion, sustained release, and varenicline previously had a black box warning tied to them because of the concerns over neuropsychiatric adverse events. This black box warning was removed in 2016, and it was removed after a large clinical trial called the EAGLES study, EAGLES, was done, and the FDA determined that the risks of serious side effects, for example, any changes in mood, behavior, or thinking, was lower than previously suspected. So I mentioned that here, and patients should be aware of the side effects and to alert you if they're experiencing any of those. But considering how varenicline is one of the most effective medications on the market, providers are still hesitant. They're, I think, still overestimating the risks of varenicline and underestimating its benefits to help people quit. The FDA updated the label on the nicotine replacement therapy products, and this was based on research that showed that there were no significant safety concerns associated with combining the products. In fact, that's the most effective way of using and prescribing the NRT. Using NRT products for longer, so some people were using it 6 months or longer, and the risks of going back to smoking definitely outweighed any risks, and there were very little to continuing use of the NRT products for longer than 6 months. The last is that because nicotine from the medications absorbs at a much slower rate, the risks of potential for abuse or dependence are extremely rare for those using the NRT products. So I think that it's important for patients to realize they won't be on these products for the rest of their life. They're literally a harm reduction. They're getting nicotine from a safer source, the medication, so they're not craving it as much from a much more harmful source, their cigarettes. And it's to help them to get past the strong cravings and withdrawal that are often most intense in the first weeks to months after quitting. But those do subside, those cravings do subside, and they won't need to be on these products for the rest of their life. In fact, the goal of the NRT is to eventually wean people off of using them. So currently, previously it was recommended that NRT be started on the patient's quit date, but currently it's recommended that NRT even be initiated while a patient is still smoking to help them cut back on their level of smoking and increase their self-efficacy. So this is a great option for patients who are feeling anxious and stressed about completely quitting, but for whom the idea of maybe cutting down or reducing their smoking seems a little bit more feasible, a little bit more manageable for them. Starting them on NRT while reducing their smoking, so they can be instructed to, reduce their smoking as much as possible while taking the gum, the lozenge, or the patch. And they can often just have these, it can recommend having their NRT in a certain place where they would be tempted to smoke, like their car, and just cut out the smoking in their car, or maybe just cut out the smoking with their first cup of coffee. So they're kind of taking baby steps towards quitting while using the NRT and getting a sense of how that works and how that helps them to gradually reduce their smoking, all while kind of building their confidence that they can do this. This is becoming a little bit more manageable for them to see how they could eventually completely quit. So this is recommended much as 2 to 6 months before a quit date, but certainly, obviously, we want to have cancer patients quit as soon after a diagnosis as possible. So again, it's just another option for those patients who are extremely resistant to any kind of behavior change, but might be more open to taking baby steps towards quitting. The last topic I wanted to mention regarding the tobacco cessation medications was the Medicaid coverage for it, since a lot of patients and providers alike aren't always aware that there is a great tobacco cessation benefit under Medicaid, and they cover all 7 of the FDA approved tobacco cessation medications. That's there are no copays, and that includes combination therapy and refills. So this, if you can give this information to your patients, that can be another way to reduce their barriers to accessing these medications. So the third leg of that stool talked about brief counseling, medications, and so the third one is support. And the Wisconsin Tobacco Quit Line can be a great option to connect your patients to more intensive support. So the role of the Quit Line is that the main barrier to providing counseling at any intensive amount in the clinic setting is time. So we encourage all providers to provide a brief intervention along with prescribing the appropriate medications, and then refer that patient to the Quit Line for that more intensive ongoing counseling. So the Quit Line, we call it a treatment extender. It can supplement or be an adjunct to the conversation that you're already starting in your clinic. So the Wisconsin Tobacco Quit Line is well supported as an effective and robust behavioral health intervention for patients that are trying to quit smoking. It can increase the chances of quitting for tobacco users 4 times when combined with medication. The services of the Quit Line are, they offer free, confidential, tailored phone-based coaching along with web-based coaching. So this can be accessed by anyone in Wisconsin, regardless of insurance, and it's for anyone 13 years and older. So we have people calling to get help to quit any kind of tobacco use, even vaping and e-cigarette devices. So basically any nicotine product, people can get support to quit. It's available 24 hours a day, 7 days a week, and can be accessed by that toll-free number 1-800-QUIT-NOW, as well as the Spanish-speaking line. So what services are available to Wisconsin residents? Provide an overview of this. Quit Coach calls, so they're talking to someone who has who's very aptly trained, who's many have 4 years, all have 4-year degrees, many have master's degrees, and many are former smokers. They're aptly trained to deal with people who have had a recent cancer diagnosis and who have behavioral health challenges, so they can certainly help a wide variety of patients with many different health complications. They provide nicotine replacement therapy, and as I mentioned, the services are available over the phone, but also via the web for people who want to engage in the coaching that way. And they also provide a quick kit of self-help materials along with what's called an ally guide. So this is for family members who want to know how they can best help their loved one quit smoking. So the Quit Coach calls cover in about 30 minutes the following. They're going to help that person to develop an individualized quit plan based on their motivation, their level of dependence, their past history in quitting, and the challenges that they believe they're going to be facing in this next quit attempt. So this is going to kind of build upon that conversation that you've already started. But as we know that the amount of time spent counseling correlates with higher success in quitting, they're really going to deep dive into some of those issues in a little bit more detail and help that patient to come up with a very individualized quit plan ahead of their quit date. Someone can call the quit line as many times as they want, so we know those cravings can come out of nowhere in the middle of the night, and if they're struggling to quit, the benefit to them of the quit line is they can call 24/7 and just talk to someone and just get support at that moment that they need it. The quit coaches are also going to talk about the NRT. The NRT is an option for anyone 18 years and older, and they get a choice of the patch, gum, or lozenge. So they'll explain how the medications are used. They'll make some suggestions and then do a health screening to make sure that it's appropriate for that person to be offered that medication. There are 3 ways to access the quit line. One is by giving your patient the 1-800-QUIT-NOW card. They can also go online to wisconsinquitline.org and sign up and do an enrollment online, and then that will trigger a quit coach to call them. But really the best way of engaging your patients with the quit line is by a provider faxing or e-referring the patient to the quit line. So next I'll talk about that program. So Fax to Quit is a program that allows providers to refer their patients to the quit line by faxing a form that just says the patient consents to having a quit coach call them. Once that happens and the quit line receives that faxed form, a quit coach will proactively reach out to the patient. So one of the benefits there is that the responsibility is not on the patient to make that first call. After they have made several attempts to contact the patient and they do leave a voicemail with their contact information and identifying themselves as the quit line, they will then fax back a form to you to kind of close the loop, let you know what happened. Were they able to connect with the patient? Did the patient accept the services, decline the services, or were they unable to reach the patient? So this is the second benefit of Fax to Quit, in that you're kept in the loop. The third is that we know that motivation to quit is dynamic, and so they may tell you while they're in the office face to face with you that they want to quit and they're going to call the quit line, but they pin that number to the fridge and then never call. So the proactive call from the quit line is really the best way to utilize the quit line services, because it ensures that those patients are getting linked up with the support, the counseling and medication, and that in turn increases their success in quitting. So I've reviewed the ask, advise, assess, and assist pieces of counseling, medication, and referral to the quit line for support. The last piece I wanted to quickly talk about was the role that arrange for follow-up plays, because this is one of the most, I think, often left off pieces. But the purpose here is that we know relapse is so common within those first 2 weeks of quitting. So this could be a check-in call or it could be an office visit. And there's really 3 goals here. Checking on the medication, how that's working, and if they're experiencing side effects, you know, maybe trying a different medication would be a good option to discuss at that point. If they've had any slips, encourage them to get right back on with trying to quit. Um, the relapse is common, so normalize that and view it not as a personal failure, but really an opportunity to learn what happened in that moment and how to avoid that in the future. So developing kind of that recovery plan and just encouraging them to stay on track with quitting. I wanted to just really quickly, I would be remiss if I didn't touch on e-cigarettes briefly because many patients are intrigued by e-cigarettes as a way to quit combustible cigarettes and may want to try them. So what the clinical practice guidelines recommends is how to address this conversation with your patients. Is that we really have limited research on the effectiveness of e-cigarettes to quit. There are public health concerns around, you know, obviously there's an epidemic around the use of e-cigarettes among youth. But particularly in adults, the concern is that a lot of people who are using e-cigarettes to quit combustible cigarettes are not completely quitting combustible cigarettes. They're still what we call dual using. And the combined effects of using e-cigarettes with combustible cigarettes increases cardiovascular and respiratory risks. So this is going to compound those risks to health. So we really encourage the 7 FDA-approved medications to be offered to your patients as first-line therapies because of the unknown risks to health of long-term use of e-cigarettes. And I think that the recent lung illnesses related to vaping has made that concern even more salient right now, is that we just don't know what are in these products and what the long-term risks to being exposed, either directly using them or secondhand vapor, what those might be. But if someone is really adamant on using e-cigarettes, encourage them to use them as a bridge off of uh, combustible cigarettes and to completely quit combustible cigarettes and then completely quit e-cigarettes. If you're interested in more information on e-cigarettes and also information regarding the lung illnesses related to vaping, Tobacco is Changing and is a great website to connect you to those various pieces of information. So in the last few minutes, I want to wrap up by talking about how our outreach program can help you integrate this knowledge into practice. So now you've walked away with some understanding of what you can do to assist your patients in quitting. But sometimes it can be daunting to then figure out, once you're back at your clinic setting, okay, how do I integrate this into the clinic workflow? First, we're a regional outreach program, so we work with healthcare systems and clinics and hospitals all around the state. I'll list the CTRI website at the end that you can go to get our contact information if you're interested in reaching out. So the pieces that we provide training and technical assistance on are some of those knowledge-based pieces, the counseling and the medications. But also more and more we're offering technical assistance on integrating the Wisconsin Tobacco Quit Line. So either the fax referral program or integrating that into the EHR. So we have some health systems that now e-refer to the Quit Line directly from their EHR. And so we work with clinics to, as I mentioned, figure out how to integrate the 5 A's and what the best clinic workflow might be that supports that. What are some of the clinical decision support tools within the EHR that will support that protocol, the 5 A's being delivered on a consistent basis, and then who should play a role in all of those pieces. We'll connect you with the latest resources for providers and patients. So if you need to find some more patient education materials, we have those on our website. We also, so we do on-site training, but we also have online training. So we have a general tobacco treatment CME for primary and specialty care providers and nurses and pharmacists. But we also have one specifically for behavioral health providers. And so that can be found at our link on the CTRI website. Last, I wanted to just talk about, because of the need for tobacco treatment in oncology settings to be addressed more robustly, NCI established the Cancer Center Cessation Initiative. So this is called the C3I, and it's a part of the Cancer Moonshot. So I wanted to just mention that at the national and federal level that this is going on. The short-term goals of C3I are to develop and expand the capacity of cancer centers to treat tobacco use among oncology patients who smoke. And then the long-term goal is to ensure sustainable tobacco cessation treatment programs that continue beyond the moonshot funding. And so there are 42 cancer centers that applied for this grant and are participating in C3I, this Cancer Cessation Center Cessation Initiative. The Carbone Cancer Center and the UW Center for Tobacco Research and Intervention are the coordinating centers of C3I. So as the coordinating center, CTRI is charged with pulling together the lessons learned from these cancer centers on how to create, implement, and sustain a tobacco cessation program in a cancer center. And we anticipate having these materials available for dissemination on the NCI website in about a year. So I just wanted you to know that that's on the horizon. And with that, I will take questions.
Great, thank you so much, Allie.
And sorry about the technical issues with the audio.
No, you did a great job. And I did have a couple questions come in through the chat box if you just wanted to touch on them or maybe just elaborate a little bit more. We had somebody ask, what is the trend in coverage under Medicaid guidelines for the cessation medications?
Okay, so I'm sorry I can't hear the audio, but I'm reading them off the chat. So does Illinois or Minnesota have a quit line for those of us who see patients from neighboring states? Yes, they do. And so there is a quit line coordinator in those states that we could connect you to learn more information about what those services are, since each state has their own state quit line and state contract for what those quit lines will provide their state residents. So they may not be the exact same as the services that the Wisconsin Tobacco Quit Line provides. But I'd certainly be happy to connect you to who those quit line contacts would be to learn more about the Minnesota and Illinois state quit line services. What is the trend in coverage under Medicaid guidelines for cessation medications? So the Medicaid coverage is that all of the 7 FDA-approved medications be covered, and that does include the combinations of the medications. It does include refills. So Medicaid has a very comprehensive benefit. I'd say that it is even more it is a better benefit than even some of private insurances. So I think as far as the general insurance market, we can look to Medicaid as a model, and hopefully some of the private insurances will increase their coverage because they may have a more limited benefit for tobacco cessation.
Great, thanks, Allie. If there are any other questions, feel free to unmute your line and ask Allie. Otherwise, feel free to put them in the chat box too.
And so, Sarah and Alex, I unfortunately can't hear you, but if there are questions, I'll just be waiting in the chat box.
Great. Well, if there are no other questions, I want to thank everybody for being on this webinar today. We really appreciate your attendance. I'm going to blow past those. Looking ahead at our next upcoming webinars, we will be hosting one on December 12th on the HPV disease and the HPV vaccination rates in Wisconsin. So we'd love to have you join us on December 12th. So thank you again, everybody, and enjoy your Thursday.